Dr. Leeds is gonna tell you a story while he drives his car on down the highway. Don't worry about him driving and talking, he's done that before. And he promises he won't look down at the camera.
The Ashton Manual is a book that helps people to taper gradually off of benzodiazepines. That would include medications like Xanax, Klonopin, Ativan, and those are really probably the most common three. And of course there's a lot of other ones. The manual does even address Ambien a little bit towards the end. And of course Valium, but Valium is an interesting benzo because the Ashton Manual recommends and describes how to use Valium as a tapering mechanism, a tapering drug. So throughout the Ashton Manual, there's a lot of tables that show examples of how a person might taper, how they would gradually transition. Say, for example, they might transition from Xanax to Valium, or they might transition from Klonopin to Valium. And Dr. Heather Ashton, explains the conversion ratio between the different benzos, which is important to know how much a doctor should put a person on when they do that transitional period, and what they should finally be on for the full duration of the taper. The conversion from Xanax to Valium is Xanax 1 milligram is the same as Valium 20 milligrams. So that's for Xanax to Valium. For Klonopin to Valium, it's 1 milligram of Klonopin to 20 milligrams of Valium, same thing. So the conversion rate for Ativan is 1 milligram to 10 milligrams. So Ativan is about half the strength of Xanax and Klonopin. But all three of them are very potent. They're high potency benzodiazepines. They're shorter acting, they have shorter half-lives. Xanax especially, Xanax has a very short half-life. It comes on very quickly and it wears off very quickly. And that actually causes a problem called interdose withdrawal, where between doses, a person can actually have withdrawal symptoms and makes them want to take their next dose, of course, because they start feeling sick in various ways. You know, they start feeling anxiety, they may have insomnia, irritability, and even gastrointestinal symptoms, pain. You know, they may have a variety of symptoms related to withdrawal, you know, where their autonomic nervous system starts becoming dysregulated. And, you know, it may be not to that extreme of, you know, it's not as bad as a full benzo withdrawal, but, you know, interdose withdrawal is a serious issue. It can make, you know, when a person tapers and they try to taper on the benzodiazepine that they're taking, for example, they try to taper by reducing their Xanax gradually, or their Klonopin gradually. There's two major issues. One is the interdose withdrawal, that a lot of the time they feel sick and they feel like they're not getting enough medication, and they, you know, are obsessing over their next dose. You know, when can I take another one? I'm not getting enough. This isn't working. And also, you know, because the tablets are so potent and they only come in so many strengths, that, you know, you can only cut a tablet realistically into 4 pieces, and even that's not that easy. You end up having to have a good pill cutter, and, you know, it takes a little practice. But yeah, so, you know, the ideal rate of tapering is between 5 and 10% for each cut. And so because you're doing it by percentages, it approximates what they call a hyperbolic curve, you know, which means that you can go faster in the beginning, but you have to slow down as you get to lower doses. And it becomes very difficult trying to do that with something like Xanax or Klonopin or Ativan, because you just don't have enough increments you can do. You can only break those tablets so much. Some people, when they do the tapering on their own, you know, they'll use a very accurate scale and measure like little crumbs of the tablet and figure out, you know, what they need to take for the, you know, for that next stage of the taper. Some people do a liquid taper. You know, a doctor might prescribe a compound that they get from a compounding pharmacy, where the Klonopin or Xanax or whatever is in the form of a liquid. But Dr. Ashton, her way of doing it, and she did this for about 300 patients, was to have a transitional period where the person switches out. They'll take their medication and split up in 3 daily doses, morning, afternoon, evening, and they'll, little by little transition, they'll switch over, one dose over to, maybe they'll take half of the afternoon dose and turn that into Valium from, say, Xanax or Klonopin. And then they'll complete that transition where the middle of the day dose is just Valium. And then they'll switch the morning or evening, little by little, and within a fairly short period of time, maybe over a course of weeks or so, maybe even a course of a couple months, you're finished with that transition and you're just taking Valium. And then, she has these tables that are, they're samples. They show you how it can be done. She didn't intend for them to be followed religiously, that it has to be done this way by these tables. Between the doctor and the patient, they can figure out what works best for the individual patient. And she even has a foreword in the beginning of the book saying that tapers need to be patient-directed. The patient needs to have input, and the patient has to communicate with the doctor and let them know that maybe they're not ready for the next stage of the taper. Maybe they need to hold a little bit longer. Maybe they're not ready for such a big drop. The doctor should not be telling the patient, it's time to do this stage and you have to do it this way. You have to drop by this amount. That should be a partnership. And I sometimes like to put it saying it's a 40-60 partnership where the patient has 60% control and the doctor has 40%. Of course, that's not always true in every situation. If the doctor knows best for something, related to the patient's safety, of course, the doctor needs to let the patient know what they're going to be doing. But as far as the rate of tapering and, that sort of thing, if the patient feels that they're not ready for another, they need to hold a little bit longer and things like that. Or, if they're having side effects and they're like, something isn't working, we need to change something. The doctor really needs to listen, and the patient has to have their input and really be in control. They need to feel that they're in control of their own taper. That's very important. But so I wanted to tell a story about something related to that. That there was a pharmacist that I talked to. So there was a patient that was in an area that I knew pharmacies might be a problem, and usually we work really well with the pharmacies. I have great relationships with pharmacies. That's something that I work hard at, and I kind of pride myself on that. That I'll call a pharmacist and talk to them and explain what we're doing. Because the Ashton Manual method, transitioning, there's a period of time where a person is going to be getting a prescription for 2 different benzodiazepines. They'll be taking maybe Klonopin and Valium at the same time, as they transition to just Valium. Or, based on that conversion rate, that 1 to 20 conversion rate, they may be taking more Valium than the pharmacist is comfortable with. For example, a pharmacist once told me they got a prescription for Valium 40 milligrams daily, a total of 40 milligrams daily, and the pharmacist said, I've never seen such a high dose of Valium. I've just never heard of that. That's unheard of. And I explained to her that, have you ever dispensed Xanax 4 milligrams daily? And she said, oh, yes, that's common. I'm like, well, did you know that 4 milligrams of Xanax is equal to 80 milligrams of Valium? So 2 milligrams of Xanax would be 40 milligrams of Valium. And, she didn't realize that. She looked it up and confirmed and said, oh, you're right. She didn't realize that Valium was relatively a fairly weak medication. So, anyway, so that's so the thing with pharmacists. So back to the story. I forgot for a second. So there's this pharmacist that I'd recommend to a patient that we might want to use a pharmacy, like a small kind of independent local pharmacy, not like a big chain pharmacy, and that might help to get better personalized care. Because one issue that you come up with, in this area, there tended to be issues with pharmacies. And I was concerned that like at a Walgreens, or that kind of place, that they have these floater pharmacists that come in and, the floaters will, they don't want to put their name on anything that they don't feel comfortable with or they feel is not normal or standard, so, if they see Valium 40 milligrams and they're not comfortable with it, there's all kinds of things that happen. Sometimes the floater pharmacist will say, oh, we're out of that medication, or I can't fill that. There's guidelines from the DEA or whoever, that your office is too far from our pharmacy, or the patient is too far from you, or they sometimes they make things up, and that's very frustrating. Anyway, so, we thought we'd try an independent small pharmacy, and we found one, that the patient was comfortable with. I called them, and I spoke with the pharmacist. He was a very nice older guy, and he fully understood everything. I discussed the Ashton Manual, I discussed tapering and how things work, and he was 100% fully on board with it. Anyway, so he filled the prescription for the patient, and we were off to a good start. The next time, there was an issue and the pharmacy wanted some clarification, and we provided that, and they filled the prescription, but reluctantly. There was some kind of issue. Third time, the pharmacist refused to fill the prescription. So I called, and it turned out it was a different pharmacist. It wasn't the nice older gentleman. It was a woman pharmacist, and she said she's documenting everything, that something is not right with this tapering plan, and she's writing pages of documentation, and she's not comfortable. She's not going to fill the prescription. She's canceled the prescription. And I asked her what was wrong, and she said, you should be on, I don't know, something like stage 5 or stage 6. She gave a number. You should be on stage 5 of the Ashton Manual. You're not on that stage now, and you're behind. Why are you not on stage 5 as of today? And I don't remember what stage it was. That there's, it's like kind of like a spreadsheet when you look at the different tables of every level or stage that you can be at. That and you make the reductions every 2 to 4 weeks. Reductions can be made. Some people do it gradually. Some people do what they call micro tapering, where every day they'll do a tiny reduction. Usually that's done with liquid. But Ashton Manual, every 2 to 4 weeks you'll make a reduction, and but it doesn't have to be by the tables. Those are examples. Those are guidelines. You can do it differently. The doctor and the patient can figure out what works best for the patient, and it doesn't have to be that fast. Some cases you may go faster. You may taper every week for a while. Anyway, so this pharmacist was very suspicious of everything. She said, you're not at the right stage. I read to her that first page, that foreword, where Dr. Ashton says, these are guidelines. These taperings should be patient directed. The doctor should not be forcing the patient to taper. And she didn't care about anything. She just kept documenting and saying no. I called back and spoke to another pharmacist. Turned out that the woman was the main guy, the first guy I talked to. Turned out she was his daughter. And at that point, I knew, obviously we're not going to get anywhere. It's not like she was just an employee that we could talk to the owner and figure something out. She obviously he's not going to go against his daughter in judgment. And I spoke to another pharmacist who he was the one who told me that. This other guy that was an employee there, and he said, he understood everything I was saying, but he said he's not going to rock the boat. He was reading pages of documentation that she had written, and he said, I'm very sorry. I agree with the plan you have, and I would help you, but in this case, I really can't do anything with the documentation she's written. She's just written all kinds of crazy things in here. Anyway, so we had to find another pharmacy. I think we found a Walgreens, and everything worked fine. We should have probably just started with Walgreens, but yeah, you can get into some really crazy things with pharmacists where I had another issue. It just comes to mind a pharmacist. This is a whole different, this is outside of the realm of the Ashton Manual and benzo tapering, but an issue with a patient who had opioid dependence. And in those cases, we use a medication called buprenorphine to taper. The tapering process in some ways is similar. The rate of tapering, and the patient feels very, they feel fine. They're able to work and get along with their family fine. They don't feel interdose withdrawal. That's true both in buprenorphine treatment for opioid dependence and Valium treatment for benzodiazepine dependence. There's some parallels between the two. Well, anyway, in that case, a pharmacist, she didn't want to fill a prescription for buprenorphine, or you probably know it by the brand name Suboxone. She didn't want to fill it because the patient had been getting prescriptions monthly for Suboxone, and then they went to a pain management doctor and they got a prescription for Percocet. And then 2 weeks later, they came back to get back on their Suboxone to resume treatment, and they wanted to get away from opioids. It was a slip, it was a mistake. And now they wanted to get back on treatment, proper treatment for, really for addiction, but for also, you can say, opioid dependence. The pharmacist was concerned that, she said, "Where's those other 2 weeks of Percocet?" And I said, that's irrelevant. Did you ask the patient why they're even getting Percocet before you filled that prescription? Anyway, the pharmacist got irritable and said, that she's going to have to report this to her superior. She hung up the phone, and funny, 5 minutes later, maybe 5 to 10 minutes later, she called back and she said, "I'm very sorry. I'm going to fill the prescription. We're going to take care of the patient. Everything is fine. They're going to get their Suboxone prescription." Turned out she went to complain to her superior, who told her the patient needs their prescription, that it's life-saving. You don't deny life-saving therapy for all the wrong reasons. And, we get into these things with pharmacists. Sometimes, they're misguided in their decisions. And, sometimes they're very intelligent, nice people, and they just want to be educated. They want to know what we're doing. They want to know how to document it. They might ask us to provide additional documentation. But yeah, that's an important part of the process. But anyway, yeah, the Ashton Manual for a lot of people is really a great way to do a taper, because when patients take Valium, because it lasts so long, it has a very long half-life. The metabolites can last 50 to 100 hours or longer, as a half-life. They have coverage all the time. They don't get the interdose withdrawal. They, in many cases, feel as if they're not even taking medication. They're able to function great at work. They function great in their family. And it just makes for a smooth taper, as opposed to, in many cases, how they feel tapering on the shorter acting, more potent benzodiazepines, where it can just be a roller coaster ride and not very easy. So anyway, that's it. Definitely worth looking into the Ashton Manual for people looking for information on how to get off of a benzodiazepine safely. And just a final word, I would recommend avoiding addiction treatment centers for benzo tapering or getting off of benzos, detox programs that are more geared towards addiction, places that say that they can get you off of a benzodiazepine in 10 days, 2 weeks, even a month. A taper in most cases takes at least 6 months, but not 1 month, or not 2 weeks, not 10 days, not a week. So some of those places, they will get people off the medication very quickly, and the person is now at risk for protracted withdrawal and more, serious complications later on. And, it just isn't a good idea to go to places more geared for addiction treatment when it comes to benzo tapering, because benzodiazepines, they do cause physical dependence, but they tend not to. Almost 100% of the time, they don't cause addiction. And that's another conversation. But anyway, thank you for joining me. Thank you for listening.
Dr. Leeds is gonna tell you a story while he drives his car on down the highway. Don't worry about him driving and talking. He's done that before, and he promises he won't look down at the camera.